Yes. So let's start without delaying. Let's start with the introduction of new members. I'm very happy to see that you have new members during this year. So let me welcome Madam President to introduce them and wishing them a warm welcome. Thank you very much and welcome, Madam President.
Thank you so much, Wilson. I really want to say a million thanks to everyone connected, to our speaker, Roland from Ireland. Thank you so much, everyone, depending on your time zone. Good morning, good afternoon, good night, or good evening. Thank you so much. Yes, as Wilson said, we have new members joining the committee for the first time. And as we step into this promising new year, I just want to extend my warmest wishes to each and every one of you. May 2024 bring us success. May it bring every one of us fulfillment and a great wealth of new opportunities in both our personal and professional endeavors. I'm actually decided to share exciting news about the expansion of this committee, a commitment to advancing education and training within the operating theatre community has led actually to the formation of the TORG Education and Training Committee over the last year. We did, I think that was about 2 webinars every month. So, and it's really been educative. The feedback has been very, very positive in terms of education, professional development, and more. And I'm just going to introduce them briefly in 2 minutes so that everyone can get to see. So the existing members, we have Anaclet from Rwanda is the chairperson of the committee. And we have Wilson, who is the vice chairperson and training facilitator for TORG. And then we've got Adenike Ajibodu. She's based in the United Kingdom. She's the secretary of the committee and the e-learning specialist as well. And we have Blessing based in Nigeria. We have Idris based in Nigeria as well. John Paul is based in Rwanda, from Rwanda, and we have Oluwatoyin based in the United States. They're all part of the committee as well. And then the new members just joining us from today. We've got Yvonne from Ghana. We have Oda Ituze from Rwanda. And we've got Hisban Fias from United Arab Emirates, based in Dubai. We have Alphonse Israel from Namibia. And we have Abdul Rahuf is based in Ghana as well. And we have Savio Adige from Ghana. And we've got 2 more members joining the team. We have Adolphe from Rwanda, and we have Clothest Aligo from Nigeria. So I just want to say a warm welcome to everyone. These individuals, they bring a wealth of knowledge, a wealth of experience, innovative thinking to our educational initiatives. Together, we aim to actually shape the future of operating theatre practices, not just locally, but on a global scale by providing us, everyone, our valued members and leaders with cutting-edge resources, courses, and most especially collaborative opportunities. It's actually a fantastic opportunity for everyone to connect with these faces beyond the educational initiatives of TORG on a global scale. You can ask them questions. You can feel free to reach out to them. If you have recommendations for the team, you can also do that and send it to them as well. I want to welcome everyone. I believe they are connected just because of our time. I'm just going to introduce them briefly here, and then if you have any recommendation, you can always pass it across to the team later on. I want to welcome everyone. I welcome the Education and Training Committee members, and together we embrace the possibilities that lie ahead for TORG. Your participation is actually key to the success of TORG, and we look forward to an inspiring and collaborative year. I wish everyone a prosperous new year that is filled with growth, learning, and shared accomplishments. Thank you so much, everyone. Thank you.
Thank you very much, Madam President. Thank you. We can welcome, it's time to welcome Mr. Idris to introduce our speaker of today.
Good morning, good afternoon, good evening, everyone. It's nice meeting everyone. Happy New Year. So I will just introduce the speaker to us. It is our honor to introduce our distinguished speaker for today's webinar, Mr. Roland Pika. Roland is a highly accomplished professional in the field of healthcare, bringing a wealth of experience and expertise to our virtual stage. Roland embarked on his nursing journey in 2014, and from the very beginning, his passion led him to the operating room department. Throughout his career, Roland's commitment to advancing his skills and knowledge has been truly commendable. It was during this tenure as an operating room nurse that he was introduced to the fascinating world of robotic surgery. Recognizing the transformative potential of his cutting-edge technology, Roland pursued further education, culminating in master's degree in perioperative nursing. His thesis, a testament of his dedication, focused on pivotal role of the registered nurse first assistants, a role that captured Roland's keen interest. To broaden his horizon and enhancing his skills, Roland journeyed to the UK, where he successfully completed a master in surgical care practice, obtaining the necessary qualifications to practice as a registered nurse first assistant. Upon his return to Ireland, Roland's commitment to his excellence and innovation became more evident as he played a pivotal role in developing one of the first advanced nurse practitioner first assistants role in robotic surgery. Please join us in extending a warm welcome to Roland Pika as he shares his insights and experience with us. His journey is not only inspiring, but also a testament to the transformative power of dedication and commitment to advance healthcare practice. Thank you, everyone. Hello.
You're welcome, sir.
Hello. Thank you for this great introduction. This is the best introduction I ever had in my life, I have to say. Thanks everybody for coming. Good morning, I say good afternoon and good evening. And I'm going to start my presentation on how to be a good assistant in robotic surgery. It's going to take about 20 minutes. And then feel free to ask questions at the end. It's going to be a 4-minute video at the end as well to add on to the presentation. So I'll share my screen if that's all right, and I'll share this. Can you all see that?
Yes, we can.
Okay. Okay.
Yes.
So like all the guys were talking about, so the previous speaker were telling about my experience. So I started my training in Ireland. So I qualified as a registered nurse in 2014 from the University of Limerick. So I was actually born in the Congo, but I moved to Ireland in 2004, where I spent most of my teenager life, you could say. I was then introduced to the robot in 2016, and when I saw it, I literally fell in love with it. My first view of the robot was the Terminator, and we're all used to seeing the Terminator. That was my view when people started talking about robotic surgery. I was like, oh my God, it's going to be like something like out of the Terminator. It was slightly different, but close enough. I then went on to complete a master's in perioperative nursing, and like the previous speaker said, I based my thesis on the role of the registered nurse first assistant. That then took me down to the UK, where I went, and fortunately for me, I had to do another master's in surgical care practice in order to become a RNFA, they call it in the USA. In the UK, it's surgical care practitioner, and in Ireland, the role doesn't exist. So it's usually candidate ANP or advanced nurse practitioner. So what is a surgical care practitioner, you could say? Well, the RCS, the Royal College of Surgeons of England definition is a non-medical practitioner who is certified to perform surgical intervention during surgery and also provide preoperative, intraoperative, and postoperative care under supervision of a consultant surgeon. That's very important. So we're always under direct or indirect supervision of a consultant surgeon, and we're an addition to the team instead of a replacement. So I'll be working alongside the registrar, the consultant, the nurses, and anesthetists, everybody in theatre. And also in the UK, my role extended to the wards. I used to go do ward rounds. I also did some clinics, and I also did some post-op visits to patients. But unfortunately, in Blackrock Clinic, I'm not doing any of that. So in order to become a surgical care practitioner, you must complete, it used to be a 2 years master's program. Now they've recently changed it to a three-year master program. This includes 1,100 hours in theatre and 1,100 hours in clinic. It's a lot of hours to do, but it really gives you a comprehensive understanding of the role, what's involved in it, and it helps you develop very good skills. And I found that Oxford University Hospital was a brilliant place for me to grow as a practitioner. So after doing my time in the UK, getting introduced to robotic surgery, working in multiple specialties, my wife wanted to come home, so I had to make a decision about how do I get home, because this role wasn't recognized in Ireland, didn't exist in Ireland. So after sending hundreds of emails, I eventually got in touch with Blackrock Clinic, which is in Dublin, Ireland, the capital, and they were interested in what I could do, and I started my role there. And eventually through that, I started developing my role as an advanced nurse practitioner in robotic surgery, and I believe it could be one of the first. Oh, sorry, was that someone speaking? So I'm not sure. It could be one of the first within the country. I cannot claim that I'm the first, but one of the first. So to date, I have done about 900 robotic assisted procedures, and that's within multiple specialties. So my base specialty during my training was urology, and that's where I did my clinics, and that's where I did my ward rounds. But then the other specialties were interested in me assisting for their operation. This included colorectal, gynae, upper GI, HPB, and thoracic, which I was just the first assistant for those cases. So let's talk about robotic surgery. So robotic surgery is new to Europe, but not new to the USA. I know the USA has been at it for longer than we are, and other parts of the world have been at it for a little while. But in Europe, it's a new enough concept. It's been there a little while, but things are starting to progress in the robotic surgery area. So we're getting a lot more hospitals buying robotic platforms. We're getting a lot more people getting involved in robotic surgery. But one thing I've noticed during my time in the UK and here is that some of my colleagues, doctors and nurses, still had very little exposure to robotic surgery. So what we did during my time in Oxford is we made a training video on how to help anybody being introduced to robotic surgery as the first assistant, and how to simplify robotic surgery, because in 20 years time we'll say, well, we're starting a robotic surgery case and it's just going to be the norm, and it hopefully be extending to other places around the world and it'd be worldwide. So what is the role of the first assistant in robotic surgery? Well, the main role is to maintain patient safety, and you might say, well, that's the role of every first assistant. But while in robotic surgery, there's one thing is that the surgeon is not by your side. So you are the sole person with surgical skills at the patient side. So you have to be on the ball to make sure that you maintain patient safety at all times. Okay, and also make sure that you communicate effectively with your surgeon who's at the console. So for many of you who have experienced robotic surgery, and for some of you who haven't, when you sit at the console, you get a 3D view of only the surgical area, the operative field. So you don't see what's happening around you, or you don't see what's happening at the patient side. So it is very important that the first assistant has good communication skills, good surgical skills to maintain patient safety at the patient side. So increased theatre efficiency. Some may argue that having a good assistant makes the case faster. That's for every operation, laparoscopic, open, and robotics. Also, as we know that robotic surgery, when it was first introduced, especially in Ireland, the main argument against it is that it was very slow. And the problem with it being slow was that it wasn't done well. The surgeons were learning, but also the surgical team was learning, and also the theatre team was learning. So when you have an efficient, safe, and well-trained team, the flow of the case goes much faster. Then you can do more cases, be much more efficient with your time. Then we believe during my time in Oxford, we believe that these skills could be divided into 3 categories. First is understanding the system. Second thing will be technical assisting skills, and that's kind of general to any operation. And then good communication, which is very, very important. So we'll go through all of them. So first thing is understanding the system.
Everything fine? Okay. So Tuesday, tomorrow is holiday. Tuesday, I'll sort you.
So first thing is to identify which system you're working with on the day. So at the moment, before, when I made this presentation, we only had the intuitive surgical available, but now we know that there's a lot more platform coming across. So I've heard of Mantra in India. I've heard of CMR Robotics in the UK. There's the Hugo who's come along quite far. So there's a lot of robotic platforms coming on board. So the first thing to become an efficient assistant in robotic surgery is knowing which system you're going to face. So I would recommend the night before, do a bit of reading, make sure that you know what you're going to face the next day. Make sure you know which system you're going to, not to get an awful shock when you come in the day, and just be prepared. Because each system, even though they serve the same purpose, they have different configurations, they have different ways to being attached to the patient, and they have different ways to be used. So the next thing, have you completed your basic training on the system? So that is very, very important. That basic training will give you the background knowledge on the steps to safely introduce instruments, safely attach the robot to the patient, and to safely manage any problems which may occur during the case, and how to manage it. So I know that some people may overlook this and say, well, it's beyond me, I don't have time to do it. I always recommend anybody that joins the team, any new registrars, any new fellows that I work with, I always recommend them to start with that basic training before hopping on that bedside. Next thing is be aware of the system of the lights. This is much more related to Da Vinci. So be aware of but this can also be related to other systems. Be aware of the warning lights. So for example, in Da Vinci, the Da Vinci systems, blue usually, there are the newer systems, the XI and the X. Blue usually means all go. Amber usually means that there are something that's funny that needs to be fixed. And red means that the system is finding something that's not right, and you may have to find an alternative. You may have to ring customer support to help you with. Usually you try not to get to red, usually to get to amber and try to solve the problem. Usually with red, you may have to restart the system. That's what it means. So just knowing those lights really, really help you. And that could be done quite quickly by looking up a YouTube video, and most importantly, by doing the basic training. The next thing is the docking step. And the docking is a very fancy word of how do you attach the robot to the patient. And that is, some people may laugh and say, well, haha, so it's so simple, but it can be quite difficult. For example, this is an example of the X system. And during our first case, during the X system, we realized that we were doing a prostatectomy supine. We realized that the patient was too far up the bed. So we had to get the X system on quite an angle to get it to attach to the patient. So these small things make a big difference in the case. The other option would have been to undrape, move the patient down, and then repaint and redrip again, which would have been a big hassle, time wasting, poor efficiency in theatre. So just knowing how to attach your system, there's a lot more systems there. So just knowing that basic will really help you. So next thing is be aware of the limits of your allocated systems. So all these systems are great, but they do have limits. And these limits can be actually related to your port placement. how you place your port. So when I'm assisting any surgeon, I always suggest, and of course, it always comes to the surgeon is the solely responsible for the care of the patient, and he makes a final decision. But as a first assistant, I sometimes suggest and say, well, I think the port should go this way from my previous experience, and you say it in a nice way. Don't kind of go into their face and say, well, I think it should be this way. But if you say it in a more polite way and make them think that you are they are thinking of that, and you may help them, because if you get your ports wrong in a lot of cases with the Da Vinci system, you'll have a lot of trouble. Also, the limitation of the system can also include for the X system, for the Da Vinci system, you may find that there's no patient clearance. That means that the arms don't, the joints with the XI system moves away from the patient if needed. With the X system, it doesn't. So you have to be careful that those joints are not pressing on the patient. These are very, very simple things, but they are very, very important. And one funny thing is, are you comfortable and is the monitor right? And it's quite funny because that's a lot of things that I hear from a lot of my colleagues saying that while robotic surgery is not comfortable, even though you're sitting, the monitor is that angle, my neck is very sore after it, I have a pain in my back from it, I don't like it. Well, the simplest thing is get it right from the start. And I'm very fussy about it. I still have to do this for the next 25 years. I want to keep my back. I want to be efficient. I want the screen facing me the right way. And that's a very simple thing. But fixing that will stop you worrying about it during the case and helps you to concentrate a lot more. And these are very simple skills. And you might say, well, I knew about this all along, or I don't care. But at the end of the day, when your back is very sore, we've all done laparoscopic surgery. We've all been there for hours, sitting there, holding a camera, holding an instrument. It is very, very uncomfortable, especially when the screen is not right. So get things right from the start. So a simple thing as well is that when cleaning the camera, don't forget the port. And this is a lot more related to the Da Vinci system. I have only experience with the Da Vinci system. I have gotten some training with the CMO system, but I haven't used any of the other system within clinical practice. So, but it's a simple thing: clean the camera, clean the port, put the camera back in. And if you forget to clean the port, you'll have to do it again, and it's just a pain and it's just a nuisance. The next things will be technical skills. So these are very simple skills, and they also can be expanded to open or laparoscopic surgery. So it's just the knowledge of anatomy and know your anatomy, know the procedure you're going to, and just be aware of the steps. These knowledge will really guide your port placement. And during my time in the UK, I used to work with the colorectal surgeons, and I worked with a couple of new surgeons to robotic surgery. And I've experienced getting the ports right and wrong in robotic surgery, and I know that some of you have done as well, and it's a pain in the ass. You just clash, stressful, and then it turns to, look, I can't do it robotically, especially with new surgeons. Let's just convert to laparoscopic. Let's go back to what we know. So that's why we said to start, if your surgeon is new to it, or if he has loads of experience, sometimes just suggest something that may help. Even something happened on Friday where there was a case where a patient had an umbilical hernia, where his umbilicus was gone, completely closed over, and he was quite low down towards his pubic bone. And I said to the surgeon, well, I think if we go above where the incision is, we might face adhesions. That's what he was worried about. I was like, how about we go higher up a little bit? And he said, well, that's a good idea, Roland, and thank you for thinking that, because that's what I was thinking. So sometimes your surgeon is thinking about it, and if you suggest something, you may help out. So know your surgeon's preference. That's very simple. Know who you're facing, know what you'll be facing, know how he does things, he or she, should I say, sorry, it's not all men. If you don't know what they're doing, if you come into the theater and you try to kind of wing it, things won't work. You'll have clashing, you'll have an angry surgeon, and not a happy theater, not an efficient theater. And the simple thing of doing that is also just talking to the nurses. I always do that. Sometimes I do some low-come case in other hospitals. I go over, I talk to the nurses, I say, how does he do this, or how does she do this? I go over and look at their preference. The nurse's preference is brilliant. You kind of see what he uses, what he does, and also ask him or her, ask the surgeon. Be like, before the case starts, you go over and say, I haven't done this case with you. Can you tell me about how would you approach this? What's your approach? Do you go posterior? Example for prostatectomy, do you do an anterior approach? Do you do a posterior approach? These simple things will make your life easier. Next thing is position the patient appropriately and safely. Obviously, that's very important in laparoscopic and open surgery, but also it is very, very important in robotic surgery, because we all know that once the robot is attached to the patient, you cannot move the bed. Cannot, big no, unless you have the integrated table. You cannot. If you do that, you would cause horrible damage to the patient. So it is very important that you make sure that all pressure areas are covered, especially for long operations. Take the time to position those patients, make sure that it's done right the first time. Do it right the first time. That's what I always say. And you don't have to worry about anything. And while assisting, a lot of people love to suction a lot of blood away from the surgical area, away where the surgeon is working. Sometimes you need to suction some blood to stop the light being reabsorbed by the blood, but sometimes you don't, okay? Especially robotic surgery, those cameras are great. They work very well. Stay where the surgical field is. Stay away. Sometimes the suction can actually be annoying to the surgeon. Your instrument hovering in the screen can be annoying, because if you sit on the console, you're so into the surgical site or the working area that when you poke something in, it does annoy them. So just be aware of where your instruments are. Be efficient with it. For example, as well, there's a picture there is, if there's a needle gone in, what I do is I bring the other needle in if you need one and take the needle out. So just minimize the amount of time you're bringing instrument in and out of the patient. And also be aware of your instrument's position on the screen. Like I said, don't hover in the middle of the screen. Don't be poking your instrument at the side. Don't make anything bleed. Just be aware of where you are at all times. So yeah, be aware of your instruments clash externally and internally with the robotic arms. That's very, very important. So when you're assisting in robotic surgery, something that may happen is that something that I've seen very rarely happen in laparoscopic when I'm doing laparoscopic cases, that you will clash with the robotic instruments, and you can see when you hit those robotic instruments, the whole hand move, and that can cause a slip up in the scissors. That can cause them slip up in the needle driver going in. So just take care. But what I do sometimes is, if the instrument is not doing anything, I use the instrument sometimes to guide myself back into the surgical field, because we know in robotic surgery sometimes the surgeon works very close to the working area. Sometimes it does happen in laparoscopic surgery, but usually in laparoscopic surgery, you can ask them to pull back a little bit. In robotic surgery, they're right up in the working field, and it's quite hard to find your way back in to where they are. So that can help. So, and then, like I said, use your suction appropriately. Don't oversuck. Use it when needed. And very important is you're going blind the instrument. Like I said, the camera is right up close to the vessel. You're trying to get there. You can't find your way. You're poking around. Next thing, you're into the vessel. So take your time, and if in doubt, ask him to pull back the camera. He or she might be very annoyed at you. They might give out to you. They say, well, you should be able to get back there, but better be safe than sorry. That's what I always say. If you're finding it hard to know where you are, always say it. And most of the time, they're very happy for you to voice that. And also, very important, always remove and insert robotic instruments under vision. And I've seen people take them out without the camera looking at these instruments. Very, very dangerous. Very dangerous. And one of the big reasons actually I got my job in Oxford was that there was an incident in which the robotic scissors, was put into an artery, the iliac artery, and there was a massive bleeder, and a lot of surgeons had to come in, convert to open, a case had to be saved, and the fallout from that after a risk assessment was made is that they needed consistent first assistant at the bedside and know what they're doing. It is very, very easy to pull an instrument out while it's holding tissue. It is very easy to push an instrument into an organ if it's under vision. So be very, very careful. And very important, like everything in laparoscoping or in open, resistance while inserting any type of instrument, robotic instrument, means no, stop. If any resistance, I don't play around. Any little bit of resistance, I always stop, reassess, and say, can I have that camera back? Because I know that in robotic surgery, there is this auto this feature which allows the instrument to return where it was previously. I always use it, but I always take care when using it, because when you change, for example, if you swap a stapler for a different instrument, it may happen that the tip. So what happens with this is that the memory in the arm goes to the tip of the instrument. So if you have an instrument with a longer tip, and you put in an instrument with a shorter tip, the instrument will go further down. Okay, so you need to be aware of that. So any resistance, always stop. So the last thing is communication. The surgeon is not by your side. Communicate clearly. Tell him what you're doing. He or she doesn't know what's happening at the bedside. They can't see anything of what's happening at the bedside. Tell them. Voice it. I always say, and people might think I sound stupid, but I always say needle coming in, needle coming out, instrument. I say scissors coming out, or some people like to say instrument number 1 in arm 1 coming out. Voice it. Always voice it. Very, very important. I mean, if you don't communicate, if you start sticking stuff in, because the thing that actually happens a lot is that when the surgeon is working and they want an instrument to be changed, but they voice it, but they're still using the instrument. That happened to me a lot. And if you pull it, you may cause an injury. So what I always say is that they say, can I get arm 1 out? And I always say, I'm about to take arm 1 out. And then they realize that, oh, they'll be like, oh, wait, Roland, I'm still using it. Let me just give you another few minutes. And then they said, can I take arm 1? And I also voice again, do you want me to take arm 1 out now? So always voice it, clear communication. And also be loud and clear when inserting instruments. I just mentioned that earlier. Just make sure that you tell them what's happening. And don't be afraid to speak up if you have concerns. I know we all work with very scary surgeons. Some of them are scarier than others. And most of the time, we don't have a voice as a first assist. Doesn't matter if you're a nurse first assist or you're a doctor first assist. But if there's any concerns regarding safety, I always voice it, say it, let it out of your heart, say it. It's very, very important that you say it. And sometimes the feedback, the comeback to it might not be positive, but most of the time it is. You'd be like, thank you for telling me, I was thinking about that, or you might just get a grunt, but always say it. And if you can't hear your surgeon, ask for some silence. And there's many cases where I've sat next to some of my junior colleagues and some of them senior colleagues, and they're assisting, and they don't hear a word the surgeon is saying, and the surgeon's getting frustrated, and you're getting frustrated because you don't know what he wants, and you're getting worried. So if we can't hear, be like, sorry, I can't hear you, repeat that. And they appreciate that, actually. And anticipate your surgeon needs. So anticipate, be one step ahead. What makes you a good assistant, I believe, that's what I've been told by my surgeons, is that you have to be one step ahead of them. And you have to communicate that to the team. So if he needs a stitch, or if you think you need a stitch to fix a bleeder, be one step ahead. Tell the nurse to have it ready before he asks for it. But don't overthink for them as well. Make sure that you stay within your level and only step in when needed. So say, oh, well, you see that there's been an injury to maybe the bladder, and you'd be like, oh yeah, can you get a Vicro stitch or a Vicro stitch or anything, or any stitch that they usually use to close the bladder with, or a V-lock stitch. Just be one step ahead. and just be able to anticipate any problem coming ahead. So I always be, yes, he'll need a needle driver for this, next stage of the operation, next stage of the operation. What is he going to do next? That's what I always say in my mind. When I'm sitting assisting, I don't think about my dinner tonight. I don't think about the TV show I'm going to watch tonight. I think about the next step. I always say, well, what is he going to do next? He's going to suture next. After the suturing, he's going to cut the bladder neck and then blah, blah, blah. Just stuff like that, is going through my head. And most importantly, robotic surgery is a team sport. Every member of the team is very important. It's not about the surgeon. It's not about the first assistant. It's down to everybody, down to the person that cleans the theater, the nurses, everybody, the anesthetist, the anesthetic nurse, everybody, scrub nurse, everybody is important. Once you have an efficient team, a happy team is an efficient team. So show respect to everybody and appreciate everybody and enjoy it. That's what I always say. So this is a video. It's only about 5 minutes video, which we made. Hello, I'm Roland. I'm one of the surgical care practitioners.
Hello, I'm Claudia, and I am a urology fellow.
We will show you 10 tricks how to be a good assistant in robotic surgery. 1. Know your equipment.
There are different robotic systems available, and you need to get familiar with the one you are using.
For example, when docking, the alignment of all the robotic arms are important with the X system, while the XI system aligns itself after the targeting.
Point the scope at the target anatomy, then press and hold the targeting button.
The setting is on.
Targeting complete.
2. Know the surgery.
Each operation has a specific approach. Proper patient positioning, choker placement, and appropriate robot approach are essential to a good start.
Surgery starts in the anesthetic room when preparing the patient. Pressure-relieving pad and strap will ensure patient stability. If needed, shave the skin to prepare surgical area. And protect other pressure points, for example, wrapping patient hands. However, be always sure that anesthetics can easily access the lines during the procedure.
3. Know your surgeon. Each surgeon has a different preference. For example, 2 left hands or 2 right hands. This means you need to be ready to assist from either side.
Knowing your surgeon makes you a better assistant. 4. Ergonomics. Surgery is a marathon, not a sprint. Look after your posture.
Before starting, have your monitor at eye level and get comfortable, either standing or sitting. Look after yourself. Good ergonomics will allow you to assist comfortably and efficiently throughout the surgery. 5. Be aware of where you are.
Sometimes it can be difficult to find yourself. Stop, rethink, reposition. Mimicking the angles of the camera and instruments may help you get to the working area.
Another trick is, if you already have an instrument there, aim for its tip. Remember, always aim up when inserting instruments into the choker.
One last trick. To stop yourself from getting lost, hover in the corner of the screen without annoying the surgeon. 6. Camera has 2 eyes.
The robotic camera has 2 eyes, which enables the 3D view on the console. This can also be used in your favor. It may happen that your vision gets blurred, but your surgeon wants to keep operating. Don't panic. Change the eye and carry on assisting.
Also remember, when cleaning the camera, be sure that both eyes are clean. A quick check will save you from having to do it again. This can be easily done using the target button.
7. Facilitate the surgery.
Be proactive, but don't overdo it. Focus on your surgeon's needs. 8. Optimize your movements.
When assisting, be efficient Make every movement count and anticipate.
Knowledge of the procedure will help you to be ready for the next step and anticipate the surgeon's need, which will allow you to be prepared when needed and to be economic with your movements.
Nine, communicate and work with your team. The surgeon is not by your side. Communicate, be loud and clear.
Don't be afraid to speak up if you have any concern.
Needle coming in. Needle coming out.
And 10. Enjoy what you do.
Robotic surgery is a team sport. Make the most of your role. Be pleasant, be kind, and enjoy yourself. Hello, can you hear me?
Yes, sir, we can hear you.
Yeah, that's the end of the presentation. Any questions?
Yes, sir, I have a question on robotic surgery. Which surgery you found that it's hard on doing on robotic surgery in urology?
Hard. I mean,
or like complicated or difficult or complex.
So the partial nephrectomies are usually quite complex. It depends on what partial case you're doing, but some of them can be complex. I think the most complex cases I've done with the urology is the robotic cystectomies. The prostate cystectomies are quite complicated. Yeah, so I always find them quite difficult because they're quite long, and there's a lot of steps to them, but they're very interesting cases. And there was one time where we did a reconstruction, a neobladder, but that wasn't done robotically. So we did a cystectomy robotically, and then we undocked, and then we created a neobladder. But yeah, I hope that's one of the cases. Usually, the cases I found the longest usually are the colorectal cases. They can take all day, and they can be quite difficult. But yeah, I hope to answer your question.
Thank you so much.
Anybody else? If not, thank you very much, guys, for listening. I hope it was all right. Feel free to give feedback to the guys, and they'll give the feedback to me. And yeah, thank you. Thanks. I'll stop sharing. Okay.
Thank you so much. I think Adelika is speaking, right? I think she's. I can't see.
Thank you very much, Mr. Roland. We really appreciate this lecture today. We are really blessed to have you. I could see that you really have a wealth of experience in this field. I was actually going to handle the question and answer section, but you've already asked and somebody has also asked a question. I don't know if there's any other person who has a question to ask Mr. Roland. If there's no other person, I was actually planning to ask a question myself, if that's all right. It's basically on how to get on the train as a surgical care practitioner, which you are. So my question is, do you have to be, because you're first a surgical first assistant, if I'm correct, before you did your MSc and then you become an SCP. So is it possible not to do the first one before going for SCP, or you can just start anywhere?
No, so I actually was just I just was a theatre nurse in Limerick, and I actually went straight to the surgical care practitioner, to the SCP. So you don't have to be the first assistant. Yeah.
Oh, okay.
You can go straight into it. It used to be 2 years, now it's 3 years, and all you need to have is 2 years experience, and then you just have to have support from the hospital that you're working in. So usually, in order to get the actual role, so what I did is I applied for a trainee surgical care practitioner role. And once you apply for that, once you get the job, the training should be in place by your hospital or your trust.
Okay, thank you.
But if you want to do it in Ireland, it doesn't exist. So I do know there are some nurses assisting, but they're not really recognized. They're just been trained on the job. And there are also some advanced nurse practitioners who do some assisting, but not that much. But none of
Okay.
them have done the course. Yeah.
Okay. Thank you so much. And again, when it comes to robotics, is it only in, because you were talking about general, you were talking about urology, is that the only field that they do robotic surgery for now? Or do they have robotics in other specialties also?
No, there's a lot of specialties. So the specialties I cover, so my background training was in neurology. So when you do the course, you have to have an allocated consultant and a specialty, and mine was urology. But once I finished my training, and actually during my training, I also did some assisting for colorectal. I did gynae. I also did thoracic when I came back to Ireland. I mean, yeah, there's your world is your oyster. There's some cardiothoracic robotic surgery going on in the UK. There's a lot of specialty. I know that orthopedics has a robot, not similar to the one we use. It's a little bit different, but they do robotic surgery there. So yeah, but what's good about the surgical care practitioner course is that you're not just trained into robotic surgery, you're trained to become a practitioner, an advanced practitioner. So that means laparoscopic open, robotics, and ward rounds, learning about the wards, the background knowledge. So it's yeah.
Okay, it's a privilege to have you once again. And like you said, we could always
Oh God, yes.
they could send feedback and we can always get to you. So per adventure, if anyone wants to probably venture into the surgical care practitioner field, would you be willing to be a mentor to any one of them? I don't know.
Yeah, that's no problem. Yeah, if you guys need any help, so at the moment I have some of the guys from Oxford doing the course now, and they're sending me messages, and I always support them. So anybody interested, we can talk about it and see how we can work it. The hardest part was leaving the UK where the role was established to coming to Ireland. That's where I found it very difficult because there was a lot of no's, but where there's a lot of no's, there's also yes. So I say perseverance. If in the country you are in, the role doesn't exist, you can always start it. And one way to do it is go abroad, get training, and come back, but you can always start it where you are. So yeah, I'd be willing to help.
Thank you very much. Thank you once again. And hopefully one of these other days would get to call you in again. Thank you once again.
Oh, yeah, be perfect. Thank you. Thank you so much, guys.
Yeah.
That was a brilliant presentation. Thank you so much, Roland, for sharing relevant knowledge with us. In relation to the role of candidate ANPs, would you mind sharing with us like salary details, prospects with that CANP roles, and how they actually how they are different from doctors' perspective, if that is okay with you?
Yeah, no problem.
Advanced nurse practitioner roles.
Yeah, so what happened to me is that I did a surgical care practitioner course in the UK. It's an advanced role. It was very good. So in the UK, surgical care practitioner, the payment for that is around 60, so between 50 to 60,000 or 65,000 pounds. That's around your wage. But when I was coming back to Ireland, I was told that the role doesn't exist here. So the equivalent I was an ANP because I met all the advanced nurse practitioners criteria by prescribing. The reason I didn't do prescribing as a surgical care practitioner is because I didn't need it for my role, but some of my colleagues did do prescribing. So when I came back to Ireland, I had to do another postgraduate in non-medical prescribing, which I just finished last year. It was terrible because I came back to Ireland after doing the 2 masters, and then they're like, "Oh yeah, you have to do this one more course," and I wasn't happy, but I did it. So then once you do the prescribing, you can apply to become an ANP. So that's what I'm about to do now. So I finished my prescribing course, and I'm about to apply. So the salaries for the advanced nurse practitioners, I think it's between 70 to 80,000 euros. It's quite good, very, very good salary. So obviously 80,000 euros, you're at the top of the scale. That's after a couple of years experience. Usually you'd be starting around maybe 69 to 70. The main difference between us and doctors is that we are not doctors. We're not medically trained. Okay, we are nurses, and our background are nursing, but we do have advanced practice skills. So we usually support the doctors in the field. Okay, so we're not replacement for doctors, and that's one thing I always say to everybody, to any doctors here, to anybody I work with. I'm not here to take your job. I'm here to work with you. And actually, because I work in the private, I don't have many juniors coming in, but when I was in Oxford, the trainees, the fellows, the consultants, they used to love me because when I assist, I used to give them time to go do their award round, to do their training, their exams, to go study, to take a day off. And then it used to be a symbiotic relationship because from them, then I learned skills, just basic skills from when I started from one of the fellows, how to suture, how to put in ports. A lot of it you learn with the fellows because a lot of the time when I was working in Oxford, the consultant would scrub in, yes, but most of the time you start the case with the fellow. And then some cases you had to do well, you were tested by the consultant then where he scrubbed in, but most of the time you're with the fellows, junior doctors. I supported them on the rounds, I supported the clinics. So you're an addition to the team, not a replacement. That's what I would say. And it's also an opportunity that you get to do some surgical skills, become an advanced practitioner. You get to step into the rounds of the doctors, but you support them, but you're still not a doctor, which is good. You're in your own role, really. Yeah. I hope that answered the question.
Yeah, thank you so much. So I presume if someone from a low and middle income country wants to be a candidate ANP, because I know that CANPs don't even exist in most African countries, they would have to start the registration from scratch. I mean, as maybe a nurse in the particular country, and then they can look at advancing, doing a course, a CANP program, just to get recognized in that field. Would that be correct?
Yeah, okay. That's correct. Yeah, so that would be the way. Yeah, sorry. Yeah. So that would be the way. So if you want to be a CNMP, there's a CNMP program here in Ireland that you can get into. So that involves prescribing. So I think it's called advanced practice nursing. I think something like that. But that includes the prescribing. That includes all the training. If you go to the UK, you can become an ANP. So a surgical care practitioner is not an ANP in the UK. So that's one thing you have to be clear. So there's also ANPs in the UK. So that's the way you can do it. But to become a surgical care practitioner, you have to be a healthcare professional. So most of the surgical care practitioners in the UK are nurses, but they are also physios and they're also ODPs. And so this is the two pathways, the UK and Ireland. I'm not sure about Europe. I went to the European Association of Urology and I've met some advanced practice nurses there. I think there was one lady from Finland. So, but I don't know what's the pathway there, but there are advanced practice role there. But I think Ireland, the UK is what I really know. And you usually have a certain amount of experience. So if you're coming from a lower income country, like any country in Africa or the Middle East, anywhere, you have to have, I think in Ireland, it's 4 to 5 years experience to start the course. And then in the UK, it's 2 years experience. Yeah.
Thank you so much. Thank you so much for sharing all that relevant information. I believe we're going to build up on that and leverage upon the skills you have shared and go forward from that. And like Adenike said, if we have anyone that is interested in mentorship or mentoring for that CANP or surgical care practitioner role, we're definitely going to reach out to you. So thank you so much for that. Thank you, everyone, depending on your time zone. A million thanks to the Education and Training Committee for facilitating this training session. Thank you, and a warm welcome to all our new members as well. We have our next webinar, which is going to be on advancement in total hip and knee arthroplasty techniques. That is going to be anchored by Dr. Ms. Samantha Truss. Miss Samantha is actually a consultant orthopedic hip and knee surgeon. She was the first Black female orthopedic surgeon in the United Kingdom. So everyone is welcome to meet her one-on-one on the 21st of January. We're going to share that across our platforms as well. Thank you so much. This webinar has been recorded. We will publish that. Thank you, everyone. Good morning, good afternoon, good evening. depending on your time zone. Thank you, everyone. Bye.